Well, happy lunch, everybody. Hello. It is my distinct pleasure to introduce Dr. Ade Adamson, my friend and colleague. Ade is an impressive guy. I think you will soon all learn and appreciate. He completed his undergraduate training in Atlanta, and then his medical degree and public policy degree at Harvard. He completed his dermatology training at UT Southwestern. We were able to, with Dr. Pignoni's help, recruit him back from his first faculty appointment at UNC to join us. And he started clinic with us here in the Division of Dermatology in July. So Ade has lots of gifts and talents and interests. He's been building a pigmented lesion clinic for us, which is en route to open. We've kind of had a soft opening, but to roll out soon. He has specialty expertise in melanoma. Of course, that's what he'll be talking about today. But I also want to point out a couple things. He is the web editor for one of the major journals in dermatology. His Twitter handle is on the screen. So if you are the kind of person who tweets and or follows people on Twitter, he's got a really interesting feed. And I really look forward to hearing what you have to say today, Ade. So thank you and welcome.
Hello? Can you hear me? Yeah, thank you for that generous introduction. And yeah, please do follow me on Twitter. I'll follow you back. I feel like Twitter is an amazing place where I learn a lot, not only about dermatology, but also about other areas of medicine, oncology, cardiovascular diseases, epi, statistics, all this kind of stuff. So I would encourage, especially the trainees, if you don't have a Twitter account, get one and follow a bunch of thought leaders that will help kind of guide you in learning more about various different aspects in medicine. So today I'm going to be talking about melanoma. I have no pertinent conflicts of interest other than I'm a dermatologist, so I may be biased in how I see and interpret data, so please challenge me. So I'm going to start with this figure. Now this figure has been something that I obsess about, and I have obsessed about since I was a resident. This is the U.S. incidence of melanoma over the last 40 years. As you can see, it's gone up in men and women, between 400 and 600% over 40 years. Why is this the case? Now, I've been obsessing about this question, and in this talk today, I'm going to offer some, reasons as to this phenomena, and hopefully you'll learn something in that regard. So I want to talk about three different parts of the management of melanoma. Primary prevention, so talk about some of its causes. Secondary prevention, I'm going to do talk a little bit about screening. And then I'm also going to talk about tertiary prevention, or giving high quality care to patients. And I do some research in all three of these areas, and I'll talk a little bit, hopefully if I have time, about all of those different projects. So I know some of you aren't clinicians in the audience, and so I wanted to first just explain what a melanocyte is and what melanoma is. So melanoma develops from melanocytes, which are the cells in the skin that give pigment. Everybody in this room has the exact same concentration of melanocytes. What makes a darker person versus a lighter person different is the amount of melanin that gets produced in these melanocytes. And these melanocytes can turn into cancer. And if they do turn into cancer, they can grow within the skin. And depending on how deep they go, they can spread to other parts of the body. So melanoma is a relatively common cancer. It's the sixth most common cancer in the United States. And about 10,000 people per year die of melanoma. The lifetime risk of melanoma has increased dramatically over the last 70, 80 years, from 1 to 1,500 back in 1935 to 1 in 75 in 2000 to now 1 in 38, right? So that's a huge jump. In Australia, it's even worse, right? With 1 in 14 men and 1 in 23 women predicted to be diagnosed with melanoma. And actually, there's a region in Australia, Queensland, which is known as the melanoma capital of the world because the incidence rates are so high. Luckily, most melanomas are caught in the earlier stages, so when they're just basically localized to the skin, and then about 9% are, caught, say, just in the lymph nodes, whereas a minority of melanomas are caught when they're, metastasized to like the brain or the lung or something like that. So 5-year survival rates for melanoma are very dependent on the stage at which they're diagnosed. So if they're diagnosed at an early stage, your 5-year survival is actually really, really good. And it gets worse, as you can see here in this table. So if we can catch melanoma early, presumably we can save some lives. So this is a sort of busy figure, which I just want to highlight the simple fact that if you treat melanoma early, it costs less. If you treat it at stage 4, those costs are a lot higher, okay? And this is data from 2010, so this is before all of the new treatments, some that you probably see on TV, like immunotherapies, targeted therapies, et cetera. And those costs are actually way higher. So they can be, a couple $100,000, dollars a year. And one of these treatments, famously, our former president, Jimmy Carter, is on, and he's had a durable response on this medication. I think we're now 3 or more years out since he was diagnosed with brain metastases. So these drugs are miracle drugs, but hopefully, but they're really costly. So hopefully, if we can catch some of these melanomas early, we don't have to put folks on these expensive drugs that also have a lot of side effects as well. So I hope I've convinced you that, there's some urgency about catching melanoma early because it kills people, it's potentially curable, and it often affects or can affect younger patients that have a lot of potential life left to live. So let's talk about the first part of controlling melanoma, and that's controlling some of the risk factors. So when you think about how melanoma develops, there are generally 2 pathways that are kind of theorized. One is the chronic UV pathway. So those are patients that have very few kind of moles, but are exposed to a lot of sun, which damages the DNA and produces or increases your risk of getting melanoma. Then there's the nevus kind of pathway, and those are patients that have a lot of atypical moles, and perhaps they get some kind of second hit, either from the sun or some other environmental exposure, and those patients, that's the way those patients develop melanoma. So it has been shown in study after study that sunlight is important in inducing melanoma, right? Probably the best kind of demonstration of that is the colonial migration of folks from Europe, the UK, to Australia. So this is a comparison of the rate of melanoma in not sunny Scotland versus really sunny Queensland, Australia. And as you can see, the rates are extremely high in Australia versus Scotland. All right. So as a result, my organization, a lot of by my organization, I mean the American Academy of Dermatology and other public health organizations, we advocate for folks to, wear sunscreen, seek shade, wear a hat, et cetera, which I think is important, right? We have promoted a lot of different public health campaigns and print and social media, and the messaging around sun protection can be like really scary. And what they've actually shown in a lot of number of studies is that what most people respond to, particularly young people, is actually appeals to vanity and not necessarily appeals to you're going to die if you don't put sunscreen on. And there have also been focused interventions. For example, a number of different communities have started to put sunscreen out in public places, and shade structures have gone up in a lot of different playgrounds. I know this is something that's happened a lot in Texas. So the question is, though, do these sun protective interventions actually work in controlling the melanoma? So the best evidence that we probably, have for this is the Slip Slap campaign from Australia, which is a national campaign in order to increase, awareness of sun protection, et cetera. And it was shown to actually increase sun protective behaviors and also decrease the burden of non-melanoma skin cancers, so that's basal cell and squamous cell carcinomas that are associated with sun exposure, but it didn't really slow the change in incidence in melanoma over time. So let's talk a little bit about sunscreen. So there's two general types of sunscreen, inorganic or physical blockers, and those are essentially sunscreens that are made of zinc or titanium oxide. You can kind of think of them as like kind of little micro sand particles that sit on the top of the skin and block or reflect kind of light. And then you have your chemical sunscreens that absorb, energy and prevent it from going any deeper in your skin. So this is a old advertising for Coppertone where they suggest that they could give you a sun tanning, lotion that will help you tan but won't make you burn. I also want to highlight this because I think that they have kind of gotten the message that this is probably inappropriate to kind of sexualize a young girl, and so they've actually changed the Coppertone brand here logo, and they've actually put a shirt on her, a hat, and some sunglasses, and now the dog is staring at her shirt and not her bathing suit. So does sunscreen reduce melanoma risk? Now, this is really controversial, so we're going to get into the more controversial part of my talk now. So there's only one clinical trial, to my knowledge, that actually answers, this question, and it's done in Queensland, where there's the highest incidence of melanoma. So this is where you would think you would get your most kind of signal if there was one. They follow these patients over 14, 15 years, and it did seemingly reduce melanoma incidence, right? But it was not statistically significant, p-value of 0.051. There are problems with p-values, et cetera. So perhaps it does decrease melanoma rates, but one problem with the study is that the folks in the treatment group were told to just put sunscreen on their face and their arms and not elsewhere. But the melanomas, as you see, develop in all different areas of the body. And the actual absolute difference between the rates of melanoma in the treatment group and the control group was the difference is only about 1%. So you would have to basically put sunscreen on about 100 people in order to theoretically avoid one more melanoma diagnosis. So sunscreen, it may help, but there aren't really great studies, and I'm talking about just melanoma here, okay? Because I know people are like, yeah, but all of these skin, I'm just talking about melanoma here, okay? So what about tanning beds? So tanning beds are also products that can increase your risk of melanoma, 20% increase. And if you get in tanning beds when you're younger, that increase in your melanoma risk actually is about 87%, increased over those that don't use the tanning bed. I don't know if you guys remember Tan Mom, you know, that eventually she was accused of putting her 6-year-old in a tanning bed. She apparently was tanning every single day. So this is her now. She never went to jail, and she was asked if she still went tanning, and she said, well, I only do it 3 times a week, but not because she thinks it'll decrease her melanoma risk, but because she just doesn't feel like going to the tanning bed 5 times a week. Thankfully, through a lot of advocacy from a number of public health organizations, including the American Academy of Dermatology, there's been a number of bans on minors going to tanning beds, including in Texas. So this passed actually while I was a resident advocating for it here in Texas. And this is a good thing, okay? And the rate of adolescents using tanning beds have gone down over the last several years. And if you actually look at the data of how many tanning salons are open, say 5 years ago versus now, that number has also gone down. With the Affordable Care Act, they also were taxing these tanning salons as well. So that might have also been part of the reason why there are less tanning salons today than there was before. So what about chemo prevention? I'm just going to say there's no real studies to show that there's any chemo preventative measures you can take, either like a pill or putting on your skin for preventing, melanoma. But that doesn't stop some dermatologists, notably this guy in Southern California, from touting the benefits of this Uvo drink that you apparently take. And I think the marketing is something like there's some plant that produces its own sunscreen, and like if you eat some extracts from the plant, then like it goes to your skin and you could be sun protected like the plant, some nonsense like that. So no. So that's basically what I want to say here. And so in terms of behavioral counseling, the U.S. Preventive Services Task Force, gives a grade B, decent grade, for counseling young people not to go into tanning beds, have some protective, behavior, sunscreen, hats, et cetera. The data is less clear for adults, and it's unclear for adults. And for those that have a lot of risk factors, say really pale skin, history of melanoma, et cetera, it's kind of on the fence about that. So let's go through this thought exercise of putting together all the kind of major risks for melanoma into one table. This is not all of them. I don't have like the genetic, factors and all that kind of stuff. But I have a mix of modifiable and unmodifiable factors here. So tanning bed use, it increases your risk by 1.5 times, 1.6 times for intense UV exposure as a kid. Family history, 1.7. Having a significant sunburn history doubles your risk. Fair complexion, about the same. Red hair increases almost by 4. And probably one of the stronger risk factors is having a lot of atypical moles. And Dr. Fox mentioned me starting a pigmented lesion clinic here, and that's to serve this sort of population that is at increased risk. So basically, does anyone know who that is? Yeah. So she basically has all of the different features that you would consider high risk. So at this point, have I convinced you all that UV exposure is really important? And do you guys think that it is responsible for that first figure that I showed you, that huge spike in incidence, melanoma? Yeah, no? Yeah, yeah, okay. So this, by the way, is like a deeply disturbing advertisement, and I'll show you why. The comparison between tanning and smoking, they're not comparable in terms of relative risk. So yes, tanning may increase your risk by 1.5 times, but smoking does by like 12 times, 15 times, 20, 30, times versus people that don't smoke, right? So these risks are not, comparable. Although I do understand how this kind of messaging could maybe help, people be more conscious about sun safety. So let's revisit this figure, right? So these relative risk increases of sun exposure, risk in, melanoma are actually not really, that high, right? And I wondered, just as a thought experiment, like, can these like small relative risk increases really explain a 4 to 6 times increase in melanoma over the last 40 years? As a millennial, no presentation is complete without an emoji appearing somewhere. So let's look back at this figure that I started off with, okay? And let's do this simple thought experiment. Let's say that in 1975, right, nobody had a history of severe sunburn at all. And then all of a sudden, we flip the switch, on, and we expose everyone to getting severe, sunburns. We doubled their risk of getting melanoma. This is what incidence should look like. Okay? Why is it like that? Well, one, is this surprising to you all? Yeah, no, maybe, yeah, okay. And it doesn't get to the question that keeps me up at night is why is the incidence going up so high? The sun really can't explain it, then, what can? So I'm gonna leave this question here, and in the rest of the talk, we'll talk about, maybe other reasons why that's the case. So let's talk about screening, something as a dermatologist that I do a lot. Okay, so in order for screening to work, it has to be in something that is common disease. Melanoma, it's not super common, but it's common enough. It has a preclinical stage. You catch it early. You can intervene. Treatment's effective. Surgical excision, can cure, melanoma, right? And do the benefits outweigh the harms? I would argue that as a field, we haven't quite sussed out that cost, balance. And is the screening tool, reliable? All right. So the most basic way to screen for melanoma is, a full body skin examination. How many of you all have been to a dermatologist before or had a full body skin exam? Okay. So the sensitivity for detection of melanoma ranges from 50 to 70%. And with the addition of dermoscopy, that super expensive flashlight with a magnifying glass on it, it can increase your accuracy by 10 to 20%. So these are different ways you can improve sensitivity. I'm going to go through a few of those. So total body photography is what I'm going to bring to the clinic, and that just involves you taking a photo or a digital photo of somebody at baseline, and then over subsequent visits, whether it's every 6 months, every year, et cetera, you just look for changes. And earlier reports have suggested that doing this can actually aid in early detection of melanoma. I promise my outfit will be, in terms of technology, it will be a little better than this here when I get it up to date. But this is just a general principle. So whether with a laptop or an iPad or a huge screen above the patient, you have their reference photos, and you look at the skin. Right, here's an example. So on the larger photo, that's the baseline picture, and then here, magnified is the, see here, the invasive melanoma. Here is a before and after, so a new mole has come up. This is under dermoscopy versus just unaided kind of view, and this is also a melanoma. So I think you understand the, like how it works. So it started to get really fancy. You know, there's this new technology where you can do 3D imaging, et cetera, you know, so where you can like look at every single mole, look at it over time, and this is like really fancy technology I can't afford yet, maybe in the future. And then there's also confocal microscopy. I'm not going to spend too much time on it. Basically, you are using the reflective properties of different structures in the skin to help you assess whether it's a melanoma or not. That's pretty good sensitivity and specificity, but it takes a long time to do, like, you know, 10 minutes, 20 minutes. And I just like looking at one, you know, mole at a time. At that point, you might as well just biopsy it. They've been trying to make this a thing in dermatology for like 20 years, and they keep saying it's about to be there, it's about to be there. It hasn't gotten there. I joke with Dr. Fox about this all the time. Then there's multispectral imaging, so just a different kind of imaging. There was a product on the market called Melifine for this. It didn't really take off, and it has high sensitivity, but its specificity is like really low, something like 10%. So it really was not that, you know, useful. And then artificial intelligence, that's a new kid on the block. They have been able to basically teach computer programs with hundreds of thousands of images how to pick out, you know, melanomas. And actually, I have a lot to say on this topic. Maybe this for another lecture. But we still have to see how this actually is going to play out in dermatology. You know, is this going to be a technology that people take home? Is it going to be something that just the dermatologist uses? Is it going to really affect outcomes, et cetera? All those questions are still up in the air. And so to sum all of this up, you know, are these methods better than a routine exam? A couple of them may be, but they're really cumbersome, you know, to use. And although I'm doing total body photography, we're still trying to get, you know, the data there to show that it is really useful. Then there's self-skin examination, you know, as well. Actually, a lot of melanomas are picked up by folks that we don't pick up in the clinic. They come with that as their chief complaint. And they've also found that married patients actually have less of a risk of presenting with late-stage melanoma, and widowed patients, particularly like, you know, widowed men, are at an increased risk of presenting with stage 4 disease. And I'm sure you guys have probably seen all of the mole maps they have, you know, online. None of them have really been, you know, proven effective. So, you know, to beware. But maybe in the future, this might be something that, especially gets married to artificial intelligence, that, you know, may be of some benefit. So is screening cost effective? You know, a lot of this is based on modeling. Some studies have shown that if you compare it to other screening methods like breast cancer, screening colorectal cancer, et cetera, screening folks at a certain interval can be shown to be cost effective. With the help of Dr. Pignoni and a grad student at UNC, who I think is coming to interview, you know, here, we have actually shown that at least in white men, and we chose white men because they're actually the demographic in which melanoma incidence is going up the fastest, and also the mortality is also going up, you know, as well. So if you're trying to model something that'll be cost effective, it will be prudent to do that in folks that are at increasing risk. And, you know, essentially what we showed is that there is a certain kind of threshold where screening these folks is cost effective. And that would be every 2 years starting at age 60. So, have I convinced you that screening is a good thing, it's effective, it's awesome? Yeah, no? Yeah, you think you should get screened for melanoma? All right. So screening makes sense, right? You know, you reduce mortality, lower rates of recurrence, you know, increase knowledge, and it's possibly cost effective, as I've shown you. But there are also harms to screening that will, you know, screening in general, whether it's breast, colon, lung, et cetera, we sometimes overemphasize the benefits and don't talk about the harms. And in melanoma, if you false positive, you can have amplification, meaning, you know, worry about those, you know, worry folks around you that are not at high risk, that they need to go in and get screened, et cetera. You can also be denied life insurance. I mean, up until the ACA, you could have this as a pre-existing condition, and you could be denied, you know, health insurance, right? And also the cost. And probably the most inconvenient fact is that there actually hasn't been definitively shown that there's a mortality benefit. So let's go back to this figure that I started with that keeps me up at night. And this is actually the part that I scratch my head about the most. Despite the fact that the incidence has gone up, you know, multiple fold, what do you notice about the red line? It's flat. It's flat. Is that shocking to you? Yeah, it is really shocking to me. Now, some people might say, well, you know, if you zoomed in, you know, there's a slight elevation, you know, in mortality. Perhaps, actually, I won't say perhaps. Yes, there is among white men, but it's slight, very slight. So, is this overdiagnosis? Have you all heard of that term before? That's essentially the diagnosis of disease that never would have been destined to actually kill the individual. And I think some of this, not necessarily saying all of it, some of this pattern here is a result of that. And now if you break down by stage of disease, most of the disease that we're catching is early stage disease. Over the last 40 years, we haven't gotten that much better at getting regional or distant disease, right? So if you're catching all of this early disease, you would think that the regional and distant disease curves would go down, right? Because you're catching those that would have been destined to have been distant or regional. So this has been talked about, you know, over and over again. Probably not enough, actually. So this is from the 90s. And then, you know, a few years back, you know, as well. This is actually known as the third rail of dermatology. I'm not supposed to talk about it in public. I'm glad that I'm in an internal medicine department, so I don't have stuff flying at me, you know, in the crowd. But this is an uncomfortable truth that we need to talk about in, you know, in dermatology. And some of you might say, wait, there's got to be some kind of data, some kind of evidence showing. We can't just be doing stuff and there's like zero evidence, right? Well, this is probably the best study that there is out there. It's an ecological study where, in Germany, where they did an educational program for a region called Schleswig-Holstein, where they educated the public about getting skin cancer screening, skin cancer awareness, all of this. They also educated some providers in how to do skin exams, all right? And they did skin exams on over 300,000 people. And what they found a couple of years after doing this is a decline in the mortality rate in both men and women. So dermatologists around the world cheered, you know, this is our evidence, this is awesome. So let's look what happened afterwards. So a few years later, they looked at the incidence and mortality, and if you can see here, it's basically gone back to baseline for both men and women in that region. And, pardon me, I didn't say this before, but after that initial study, they opened up screening across the country, right? And so across Germany, mortality rates during this whole time really did not change, at all. And like I said, they went back to baseline in the region that they performed the study. And as you can imagine, this is incidence rates of melanoma in Germany, they shot up. Right? So the shortcomings of the study, it was observational, there was no control group. There was no way to actually follow the individuals that were screened. And it took screening 620 people to find a melanoma. And actually, the stat that's most shocking to me is that in the screen group, the rate of melanoma that they found was 162 per 100,000 versus those that are unscreened. And so the reason why that's shocking to me is because the implication basically is that in an unscreened population, you're missing or potentially missing 7x amount of melanoma that is just hanging out there. In the United States, they're doing a study of screening in a large population where it's happening in Pittsburgh, where they've educated a bunch of docs in the health system about performing skin exams, and they have a group of folks that are in the screen group, so they get screened at least once a year, skin cancer. You have a group in that health system that aren't exposed to that. Okay, and this study is a one-year kind of look at the outcome. And so what I want to draw your attention to is in the screen group, the incidence rate of melanoma in situ and invasive was over 45, and the incidence rate in the unscreened group was much, much lower, statistically significantly different. And as you can imagine, they found less thick melanomas, right? The really thin ones of 1 millimeter or less. But there was really no difference in them catching any of the thick melanomas, the ones that are more likely to actually harm you, right? And so I hate to drag my professional society, but I talked about this actually on Twitter, and a number of folks in that organization, including leadership, follow me, so they know my position on it. So we have a public health campaign, it's called Spot Me, where dermatologists go out, set up a tent, screen people, and they released the data from 30 years of screening. They screened over 2 million people, and they found 20,000 melanomas. That's an incidence rate of 1,000 per 1,000 per 100,000. When I showed you that figure that keeps me up at night, that figure is 70. So what's in the population, right? So in this screen population, they found 1,000 melanomas per 100,000, person. And so this is it broken down by age group. Now again, these are clinical melanomas, so these aren't melanomas that were actually biopsied, pathology proven, et cetera. But even if only 1 out of 10 of them were actual melanomas, they're just finding tons and tons and tons of disease, right? And this phenomena of going to look for, of cancer can actually induce you finding more cancers that might not be clinically relevant, was beautifully done by Gil Welsh and colleagues here, where they basically showed that the more you do biopsies, the more melanomas you actually found. And melanoma is not the only scrutiny-dependent cancer, meaning you'll find more of it if you go looking. There's thyroid cancer. So this is from South Korea. So in South Korea, they The government basically added incentives for people to get screened for various cancers. They did not include thyroid cancer as one of those cancers, but providers, with the help of in-office ultrasound, could actually, for a little fee, also do thyroid screenings. And those screenings led to a huge spike in the amount of cancer that they found. As you can see, there's no difference in mortality. This is the data from the United States. Breast cancer is another one as well. The introduction of mammography has, led to a huge surge in the amount of small breast cancers that have been detected. So this is the case with a number of different, cancers, all with their own unique kind of, stories. But this provides, at least reassurance to me that this is probably something that's happening in melanoma as well. And so the task force, as a result, because there's, not great data supporting population-based screening for melanoma, that it gave it an I decision, which is, inconclusive. And I think Dr. Pignoni actually was on the task force when they came up with this recommendation. And a number of folks from my field were very upset, by this. And so why hasn't there been a clinical trial? Well, it takes a lot of people, and you got to follow them for a long period of time, and it's expensive. But I would argue that the amount that we're actually spending now on treating indolent disease probably is more than this estimate in terms of, cost. So should you get screened with melanoma? It's uncertain for the general population. Perhaps if you have a lot of different risk factors, and like I said, the clinic that I'm going to open up is for those that are at high risk. And maybe in melanoma, overdiagnosis is okay, having some of it. Maybe it's tolerable because it's, just a simple biopsy or a simple, excision. It's not like whacking off, a breast or, dropping a lung, or leaving somebody impotent and incontinent, right? But we actually haven't quite measured what those harms actually are. Am I okay on time? Okay, so I'm going to blaze through this. This is treatment. This is some of the work that, that I'm doing. So the basic paradigm, for treating melanoma, you find it, you biopsy it, a pathologist reads it, you cut it out, and if it's too deep, then a medical oncologist, somebody else, has to take care of it as well. Dermatologists mostly diagnose most melanomas, but really it's anybody that can do a biopsy. And dermatologists treat a bulk of melanoma, particularly early phase melanomas. But if they get much larger, then other folks are involved as well. And surgery is the mainstay, though, of treatment. And because there are a lot of different kind of cooks in the kitchen, it's possible that some people can fall through the cracks. And so, and some of their treatment can be delayed. And it's important to study delays because delays are also a measure of quality of a healthcare system. And delays in surgery have, for various cancers, have actually gone up over time. And this can also lead to, poor outcomes for patients that don't get their surgeries, on time. Less work has been done on this question in melanoma. There was a study in 2015 that basically showed Medicare patients, 1 out of 5, had a risk of having a delay in their surgery. Delay is about considered 6 weeks. And those that were diagnosed by a dermatologist actually had a less chance of, having a delay. And what the study didn't answer is it didn't look at other insurance types and also younger patients that get melanoma. And there also was some coding and misclassification that were potential issues as well. In North Carolina, there's this data set that marries the cancer registry data with both private Medicare and Medicaid insurance. So you're able to really get a nice snapshot of a large population. with cancer. And so I wanted to know, did insurance type matter in your risk of getting delays? I'm going to blaze through this here. So this is basically just showing you that my primary outcome was excision of 6 weeks or greater was the delay. And essentially what I show is that if you had Medicaid, if you had an increased risk of a delay in your surgery as compared to private insurance. That risk decreased if you were seen by a dermatologist for the diagnosis, or you actually had it excised by a dermatologist. And if you were non-white, you also had an increased risk of having a delay in surgery. And so I'm going to, pursue this question further to see if there's a survival benefit, whether patients are getting guideline concordant care, and try to address this potential disparity in the delivery of high quality, health care. So my conclusions to this study, to this talk are essentially that, sun exposure, at least I hope I've convinced you that sun exposure on its own can't explain the incidence of melanoma or the epidemic. Screening is not definitively shown to save lives in average risk patients, and we should focus on delivering high quality care to our melanoma patients. And I want to thank everyone here, especially Gil Welsh, who I've been collaborating with over the last year and has been an awesome mentor. And he's probably one of the world experts in the issue of overdiagnosis. If you guys have any questions, thank you. Follow me on Twitter.
So before I go take my sunscreen off and don't excise the melanoma later,